and welcome to the Wednesday morning roundtable. My name is Tom Minicucci. I'm the manager of the Health Central Medical Facility along with Dr. Joya. Dr. Joya is also part of the Auburn Community Hospital and the Health Department. We'd like to thank our staff. We have Jesse Klein, who organizes everything, and Rob Auckman, who helps us out with all the IT issues. We have 3 presenters today on the COVID-19 issue. The Auburn Community Hospital has 2 presenters. One is Abby Gunger, and is Auburn Community Hospital's Vice President of Quality Management, and the other is Dr. Mike Wilson, Chief Medical Officer of Auburn Community Hospital. They will focus on the clinical nature of COVID's response by the hospital. The other presenter is Nancy Purdy, and she is the Cayuga County Health Department's Associate Compliance Officer. She will clarify questions concerning public health protection measures and policy. We also want to thank our sponsors. We have Tompkins Trust, the membership of the Wednesday morning roundtable, Wegmans, the Emerson Foundation, and the Allen Foundation. We also want to say that again, that this is going to be open to the public. So our first presenter will be Nancy Purdy from the Health Department.
Thank you. It is a pleasure and honor to speak with all of you today. First, accept my gratitude in the many ways you may have contributed to provide support during this pandemic. Possibly, you assumed new duties at work. You may have willingly collaborated and formed partners with other teams and organizations. You may have facilitated your workplace in obtaining vaccines. You may have provided support to ill family and friends. You adapted to the restrictions placed on you, your family, and friends. You may have supported local businesses. You may have read a book to comfort a child. You may have listened to a person's expression of grief. The list of possibilities is endless. Thank you for supporting and providing for our community. COVID-19 is now the 3rd leading cause of death in the United States. 950,000 deaths have occurred. Keeping in mind, the true toll is likely unknown because deaths have gone uncounted. We are reckoning with a new virus in the world and have been in a constant state of learning, personally, professionally, and socially, to adapt and overcome an overwhelming disease. After the US passed 100,000 deaths, recorded deaths in 2020, the county legislator had asked me to come speak as to the current status. And after reading an article in the Harvard Review that I thought was most interesting and most purposeful, the theme of my presentation was the grief experience. Universal grief. Every person, every adult and child experiencing grief, encountering illness, death, loss of normalcy, economic loss, loss of connection, and experiencing anticipatory grief, whereby people are harboring feelings of the worst that can happen. We have been collectively grieving. The stages of grief are universal human behaviors that enable us to respond, cope, and accept a loss. The stages are not linear, and we bounce around throughout the stages during our experience of grief. Stop and think about this. All of us have been moving about in the stages of grief. The ability to cope and function as we have speaks of the human fortitude and resilience. In 2020 and 2021, and again, I was speaking to them in 2020, I was expressing that every conversation we have with individuals throughout the community all day long into the night had a thread of expression of grief. Within such a crisis as a pandemic, our vulnerabilities and weaknesses will surface in our communities. Examples: the drug use, the mental illness, child poverty. These problems existed before the pandemic and were exacerbated by the pandemic. In 2022, there are indications we are moving on beyond the pandemic. Are we past the pandemic? We'll answer this question together. Next slide. To enhance communication and understanding, we know the importance of shared understanding of term definitions. Let us review several definitions in our quest to answer our why question. Pandemic. World Health Organization declares a pandemic when a disease growth is exponential. The growth skyrockets in with each day, cases grow more than the day prior. It covers a wide area affecting several countries and populations. An endemic. A disease outbreak when consistently present and limited to a particular region. The spread and rates are predictable. For example, malaria considered an endemic in certain countries and regions. Next slide. Epidemic, unexpected increase in the number of disease cases in a specific geographic area. Smallpox, measles are prime examples. In fact, within the last decade, we had a measles outbreak downstate in an unvaccinated community. That was an epidemic. Epidemics, interestingly, are not confined to diseases, to contagious diseases. Smoking and obesity considered epidemics when rates are clearly above the expected occurrence in a community or region. It is predictable. The difference between these definitions: no, it is not the severity of the disease, but the degree to which it spreads. So for COVID, if you suffer cold symptoms versus hospitalization, it isn't about the severity, it is about the spread. SARS-CoV-2 is yet to be predictable in the number of cases and how much it spreads. Thus, the answer is, I think we all can agree to, based on our definitions, we remain in a pandemic. Consider, I want to utilize flu as in relationship to these definitions. Seasonal flu happens every year, fall and winter in the United States. It's predictable and experienced in North America, fall and winter. Other continents experience flu in different seasons. It's an epidemic. In the last 100 years, there has been 4 occasions of pandemic of flu, with new flus accounting for that. Next slide. Over the course of the pandemic, the data collection and reporting of the spread and severity has been critical in strategizing and protecting our populations. As you're well aware, the number of cases, deaths, hospitalizations, isolations, and quarantines have been recorded and reported. Over the same course of time, immunity has been increasing through vaccinations and persons actually having the infection. Therefore, we now are in a place that we need new measuring data points to monitor the spread. The new CDC County Tracer measures risk in designations of low, medium, and high, determined by hospital, COVID admissions, and occupied staff beds. So here we are again in a state of constant learning, and it is ongoing. As we resume activities without mitigation safety practices because of the reduced number of cases and the reduced number of hospitalizations, it is now necessary for all of us, all persons, to personally consider the risk for themselves and community and take the necessary actions to ensure everyone's health. For consideration, how do we go about doing that? Well, we live in an elderly community. Elderly persons over the age of 75 are 140 times more likely to die than persons in their 20s. Among vaccinated people, those who are immunized compromised are significantly at risk for severe illness or death. Unvaccinated people are 53 times more likely to die of COVID than vaccinated and boosted. At this time, we also have competing priorities. We need our children in school. We need the ability to travel for work and family. And thus the rules for masking vary because we're assessing personal risk and benefits. This can create confusion among all of us. Again, we may remain in this constant state of learning. There remains a need to predict ongoing, next slide, please. There is a need to predict ongoing spread and spike in cases with multiple data points. The use of multiple data points provides us greater accuracy in predicting trends of spread. Monitoring the composition of community wastewater for the SARS-CoV-2 infection serves as an early warning system for identifying increased spread. Since so many of our COVID tests are performed outside the healthcare arena now and are not reported, with all the home tests providing greater access of testing, which is really great. Water surveillance will, though, capture a rise in cases within a region and throughout New York State. Wastewater surveillance has been used in communities to identify outbreaks of hepatitis A, for instance, and actually community use of opiates. It is important to mention the water does not contain live virus, but rather the result of shedding that likely occurs after the second or third day of having the infection. Next slide. A few remarks in respect to vaccines I have for you. In April of 2020, pharmaceutical companies and partners around the world collaborated and prioritized the creation of our vaccines. Resources and money and manpower were extraordinary. We were building manufacturing structures at this simultaneously when we were conducting trials and studies. By doing that, it enabled us to arrive to have these vaccines. There were no shortcuts taken. There were more resources put to the endeavor. The mRNA technology has been in development for over 30 years. The structure had been created and awaiting a need. Interestingly now, it is hopeful that this same technology will be able to be used for cancer treatments. Next slide. Currently, Cayuga County vaccination rate is less than 65%. To achieve community immunity, we need to achieve 85% vaccination rate. We need everyone vaccinated. This is sometimes confusing. Again, we're learning. When we go to the hospital with a laceration and they suture us up, they check our tetanus status and they tell us, you need to have a tetanus booster. And we go ahead and we get that. Because tetanus still exists, none of us know of a tetanus case, fortunately, because we are all vaccinated. But there's still a risk of getting tetanus. And thus, we must maintain a level of titer within us to not succumb to tetanus. Another example, whooping cough. Over a recent decade or more, whooping cough has had a resurgence. We're all vaccinated. Well, gradually weakened protection from vaccine is the reason why we now have whooping cough. Some adults require additional boosters when titers are found not sufficient. Children receive multiple doses to prevent measles, mussels, and whooping cough. There's also been a question raised about what's happening for vaccine for children under 5. It was not advanced for consideration because it showed to have weak protection against the Omicron virus. Again, going back to my earlier statements that no shortcuts were taken, this is proof there's no shortcuts taken. It was retracted until further studies could be done. The problem is likely the dose and not the vaccine. Next slide. Our unified desire is to return to normal. I suggest we strive to achieve a new normal, allowing us to bring forth our new learnings, our new strategies for achieving effectiveness, and go forward with the many collaboration and partnerships we have created. While we remain in this pandemic, we likely to experience further grief and live in a constant state of learning. I recommend a readily available antidote accessible to each of us: the expression of genuine gratitude. Please consider conducting this experiment. The next time you express genuine gratitude, notice and pay attention to how you feel. You express gratitude rightfully to acknowledge someone else, likely without thinking how it benefits you. You likely will notice it provides you immediate solace and comfort. Please accept my gratefulness for sharing your time with me today.
Thank you very much, Nancy. I greatly appreciate that information. Our next two presenters are from Auburn Community Hospital. We have Abby Gunger, who is a BSN RN MBA. Abby is responsible for managing all aspects of hospital and skilled nursing quality measures and programs. She evaluates risk and development of preventive action at Auburn Community Hospital, as well as monitoring provider success and plans for performance improvement. Abby is a member of the executive COVID-19 response team. Also with these responsibilities, Abby monitors regulatory compliance and the preparation for surveys and specific experience with the Joint Commission, New York State regulations, and CMS and OSHA requirements. The Quality Management Department is responsible for quality, patient safety, and risk management, including the Care Transitions Department, case management, social work, discharge planning, and on-call social work. And the hospital-wide infection prevention and control program. Abby has held several management positions in nursing, including director of nursing at the Finger Lakes Center for Living, and has earned her BS Masters in Business from Cayuga College. In addition, we have Dr. Mike Wilson, Dr. Wilson is the Chief Medical Officer at Auburn Community Hospital and is a surgeon and Auburn orthopedic specialist concentrating with patients with traumatic injuries and complete care of foot and ankle issues. Dr. Wilson completed a fellowship in adult orthopedic reconstruction at the Brigham and Women's Hospital in Boston, Children's Hospital, and served as Chief of Orthopedic Surgery at the West Roxbury Veterans Hospital and the Faulkner Hospital in Boston. As Assistant Professor of Orthopedic Surgery, he founded the Harvard Fellowship in Orthopedic Foot and Ankle Surgery in 1995 and trained dozens of fellows and hundreds of Harvard residents in foot and ankle surgery. So I want to thank you both for agreeing to attend this, and I will let you proceed. Thank you.
Well, thank you very much. I'm Mike Wilson, and it's a pleasure to be with you today. We're all recapping the last couple of years of our lives and how deeply this virus has affected us in traumatic ways, but also in very positive ways. And I think Nancy did a beautiful job of summarizing the stages of grief, which I think a lot of us grew throughout this process. For those of us that are lucky enough to have escaped the ravages of the virus. Today, I want to focus on Auburn Community Hospital, which is basically the main healthcare provider for Cayuga County and parts of Seneca County. We also want to stress the wonderful cooperation that we've had with the Department of Health. Nancy and Kathleen Cuddy have been a pleasure to work with throughout this process, and the cooperation of a healthcare system with a government Department of Health has been rewarding, but also has given us the opportunity, I think, to respond to an unusual challenge, one that we didn't really understand at the beginning. In many ways, we're still struggling to understand it, but it enforced the value of teamwork and compassionate action by its members. Next slide. Today, we want to focus on a couple of items that will, I think, give you an excellent idea of how we have, as a small community hospital, but a very vital rural hospital, responded to an unusual virus challenge. As you know, COVID-19 is a SARS variant, and it has, we can stay on this slide, thanks. It has presented us with variants, which is really has been keeping us on our toes, has presented us with a moving target. We all remember the Delta variant, and now we're at the tail end, hopefully, of the Omicron. We can talk about that a little bit as we go forward. This is a slide showing us over the last couple of years how the case per day rate has varied. And you see two spikes, one a little over a year ago, where we peaked at about almost 100 cases per day. This is Cayuga County. And then we pretty much went down to a baseline in March of last year. And we kind of simmered along until the fall when we began to see an increase. And then in December, we identified the Omicron variant, which, as we remember, started in South Africa. And I remember when the first couple of cases came to New York City, and the spike, the slope of the spike of the Omicron was remarkable. And it peaked at around 200 cases per day in our county. And we can see now we're in early March, which is the very right-hand edge of your graph, that we're coming back down to baseline. And we haven't seen any significant upswing over the last several weeks, which is very gratifying. So we have a nice bimodal tracing here for the COVID behavior over the last 18 months or so. And we can see that it's really primarily a December and January virus. We don't know if this pattern will be repeated next year. It's very likely that it will be. And hopefully we'll have a booster of some kind in the fall, which will be tailored to whatever the prevalent variant is at that time. Next slide. Hi, Robert. Next slide. Thank you. Okay, so go back one. Thanks. Robert, go back one. Thanks. Okay, so Nancy talked about vaccines and how we have not really exceeded 65% countywide, which is, it's low for the state of New York, it's low for the country of the United States. We haven't really flatlined in terms of increasing vaccine rate, but you can see that the slope was quite steep early on. So we had a lot of early adopters and people jumping on the bandwagon. And now we are creeping along at around 62% countywide. The booster curve is down at the lower right. About 32% have had their booster. Next. If we look at deaths per day, we see two trends that sort of mirror more or less the daily case load. Last year, we had many more deaths with the Delta variant, and it was rather dramatic in the winter last year. The Omicron, even though it was very, very aggressive in terms of spread, did not register the same number of deaths as Delta, partly because I think we've learned a lot about how to treat the COVID virus in general, but also the nature of the virus appeared to be slightly less virulent, and we had a much higher percentage of natural and vaccine immunity in the community. So we don't see the huge spike in deaths that we did with Delta last year. Next slide. Overall, COVID has been a relatively fast-moving virus. Locally, in March of 2020, Cayuga County announced its first confirmed case of COVID-19. So you can see that's almost exactly 2 years ago. A month after that, we had our first death. And then things rapidly increased. 100 confirmed cases, 1,000 confirmed cases, 100 cases in a day, accumulating up to over 2,000 confirmed cases. In January, where we saw that very large spike previously, we had the highest number of active COVID-19 cases at one time. And Auburn Community back in January of last year had 46 COVID related patients at the hospital. And don't forget, we're a hospital of about 95 beds max. So we had close to 50% of the beds in the hospital were COVID related, which was just very, very remarkable. March. Yeah, go ahead, that's fine. So things have slowed down. Now through this process, the government was very active, and we can all remember how the state agencies were sort of running, driving their planes without much radar. They didn't really understand everything about the virus, but everybody was doing the best they could. The New York State declared a state of emergencies. The schools were closed for quite a while. We were trying to do screening. Some of the early tests were not particularly effective. We did try to use negative pressure early on in the hospitals. We restricted visitation at the hospitals. All employees were wearing masks and face shields. And early on, we were doing surface cleaning religiously, which appeared to be not a bad idea, but not critical for the aerosolized virus. We had occasionally shortages of the masks and PPE. Ventilators were in a great supply eventually, and we fine-tuned when and where we're using ventilators. For a period of time, we shut down elective surgeries, which caused great inconvenience because we define elective not trivial, but non-essential. So surgeries that would be otherwise performed promptly were delayed. We had problems with reagents for testing and lab procedures. And then, of course, we've had vaccine and booster mandates throughout, and we still have a mandate in effect in the state for the booster. And our hospital will be struggling to have everyone boosted in the next couple of months. I'm sure we'll be successful in that regard. Next slide. Now, Abby can give us a little idea about how we, as a hospital, navigated this very challenging and quite damaging virus over the last 2 years. Thank you, Abby.
Yeah, thank you, Dr. Wilson, and thank you for having us today. So I'll talk a little bit about the details of the response of the hospital and how it evolved over time. So initially, I just wanted to share, I think we here at the hospital were like everyone else in the community, just kind of following the news and thinking, oh, this virus is, overseas. We probably won't be dealing with it. And then, unfortunately, we all heard the same news that the first case was identified in the United States, and then, of course, in New York State. So once that case was identified in New York State, the executive team here at the hospital, we pulled together what we call our COVID response team. Basically, the way a hospital operates when it comes to emergencies or attempting to prepare for them is we write plans. Those are state mandated plans, and most businesses have them. In particular, we did have a pandemic flu plan. So we thought, okay, we're going to activate our emergency response in our command center and take a look at that pandemic flu plan. So we open the book and we begin to go through what this response would look like. And it really did help us in setting a baseline of how we would respond to the pandemic, although we quickly found out that we would need to be very flexible and adapt to change very rapidly over the next couple of months. In particular, we identified immediately that we were likely going to have issues with personal protective equipment. And I know that this was all over the news, and so I'm sure you recall that we were following CDC guidance and how we should protect our staff who would potentially come into contact with infected patients. With the testing being the way that it was at that time, a 6 to 14-day turnaround to get a result on a COVID test, we had to make sure that we had everything we needed to protect our staff. It was our number one priority, obviously. So again, we quickly realized that was going to be a problem. And I want to emphasize this more than most things I'll point out today in the presentation, only because I think that was truly the beginning of many relationships that were developed through COVID. And I can't emphasize that enough. The local Cayuga County Emergency Response Office, the Cayuga County Health Department, the police force, I could just go on and on. explaining to you the development of beautiful relationships and the amazing response that this county has, and how they showed if we could all get together and communicate and get on the same page, we could do a lot of great work for Cayuga County, and that happened. So with regard to masks, I want to talk about the Cayuga County Health Department and their assistance in helping us obtain masks from supplies that were available in Albany. So as we struggled with our own ability to even purchase masks, and that was based on vendors, they were limiting the number of masks that you could purchase, and gowns and ventilators, you name it, all PPE was very difficult to come by. So that was our first task, ensuring we had that. Next was taking a look at all of our infectious disease protocols, and how do we deal with something we don't know much about. So over time, what we discovered was, we would just go to the maximum protection. We built negative pressure units here in the hospital. And it was amazing to me how we were able to turn full units into just regular med surg unit into full isolation units overnight, with the support of the New York State Health Department and our local partners as well. It is unusual to have approvals to make any modifications within a hospital within 24 hours. So where I come from in terms of the regulatory world, you have to know that was just an amazing experience and partnership that they showed, and commitment to the safety and care of our patients. Additionally, we thought our doctors, they don't know how to deal with these patients. We have all these physician offices, like, what do we do? So we were able to implement telemedicine practically overnight with the assistance of our former CMO, Dr. Paul Fu. That was an experience for some of our providers who have been with us many, many years and could have never imagined the day would come that they would see a patient over a Zoom meeting such as this one. But we acclimated and we moved forward. We were approached in March by the health department locally. And the question was, we really would like to have a location in which we can see the COVID patients that are ill and keep them, isolated so we can prevent infection. Is there any opportunity to do this? And so the idea came about that we would seek to open a clinic in partnership with the county health department in the Cayuga County nursing home location. And we were able to submit a plan and have that approved in 6 days. We began seeing patients there, and we ran that clinic for 5 months with quite a bit of patients coming there to that clinic. We didn't expect to see so many. We ultimately began to see migrant workers from all over the county, in which the county health department locally would transport them to be seen. So it was a real great opportunity to think outside of the box and serve community needs. In addition to that, we ultimately ran multiple testing sites together. We had a great system going. I think Nancy Purdy would agree. Nancy's team would collect the specimen and our lab would run the test. Now, remember, initially, we had no access to rapid testing or any platform. And it wasn't until approximately the end of March that we were able to obtain 3 platforms for rapid testing here at the hospital. And at that point, that's when testing really started taking off. We could get a result back within an hour versus 6 to 14 days. So I feel like that was a turning point for not only our patients in the hospital, but certainly the community surveillance and isolation of cases in an attempt to reduce spread. Also, I'd like to mention that the county offered the hospital a van in which we utilized for transportation of our COVID patients. There were many, many barriers that existed in the community in terms of caring for our citizens affected by this terrible virus, and definitely transportation was one of them. You know, the Cayuga County health nurses could not come and pick up patients here and transport them home. There was just so much going on out there in the community that was a priority for them. So we received the van and we drove patients all over the county home when there was no one else to do it. So that was also part of our partnership, and I do appreciate all of the support that we've received here at the hospital. I have to say, there was one day that we were meeting with regard to the downstate infection rates being so high, and there was a state meeting in which they were looking to get ventilators from hospitals. And much to my surprise, I walk into our CEO's office, Mr. Scott Berlucci, and he is on the phone with the Governor Cuomo at the time. It just amazed me that even our state government came down to the level of communicating individually with the hospitals and really demonstrating commitment and passion to get things back on track and to help the citizens of this state. And so for that, we are very grateful. Staff education was rapid. It was one of the things that we knew that was going to be the challenge. Communication styles changed. We, to this day, are not in person in meetings just based on risk and some of the size of the meetings that increases our risk if we are in the same room together. So we had to rapidly figure out, how are we going to communicate with our staff, the community, all of our stakeholders, everyone who's interested in what's going on at the hospital, our patients, their families. So we developed a website that we were able to communicate to the public. And this is in addition to what we would normally have explaining services at the hospital. We communicated daily with our medical staff and our key leadership so that that could be communicated forward. And obviously we met almost daily with our local partners to figure out what our next moves would be. And then public updates, a lot of information going out in the newspaper and social media, especially as it related to the impact of visitation. Visitation was very difficult to say, sorry, we cannot allow you to come and visit your loved one. So there were a lot of questions around that and a lot of work to be done to ensure that we communicated that properly to our families of our patients. Thank you. Next slide, Matt. Physical changes, as I mentioned, obviously we had negative pressure units. We added negative pressure rooms in our ER. CCU also negative pressure. We implemented a screening tent outside of our ER and asked our employees to please work outside in the winter to screen patients to make sure that we could keep everybody safe. And without them, without our employees, we wouldn't be here today with such a wonderful story to tell, I assure you. And then all of a sudden, hope came around the corner. And that was notification from the CDC that we needed to prepare to be a mass vaccination site. Now, that information came 2 months prior to actually receiving the vaccine, so you could only imagine how excited we were about that. We actually received our first doses in December. I believe it was December 22nd, and we vaccinated 10 people that day. We're like, okay, we have to do a trial run. And since then, we have given over 10,000 doses of the vaccine. So we are very committed, just to reiterate Dr. Wilson's point, to getting our community vaccinated and our employees. And we're very excited about new treatments and therapeutics for this virus, in hopes that we can see a brighter future. Thank you. Next slide. And I think we talked a lot about teamwork. Without a team, this would not be possible. None of the success of this community during this pandemic would be possible. But I do want to point out that even through our own challenges, we had RNs who, stepped up to the plate and said, I am going to go down to New York City and I'm going to work in a tent or at a hospital, and I'm going to take care of COVID patients. So we saw just the human response, just incredible. Thank you, Matt. Next slide. So I touched on vaccines, and I will just say with testing, you'll see here that we've processed over 52,000 COVID-19 tests just in 2021 alone, which averages about 141 tests a day. And we are so fortunate to be able to offer testing to the community. We started out with 6 to 14 day turnaround to an outsourced lab to a platform. You see here, this is a Abbott ID Now bank that you see on this slide. And this is a rapid test that is absolutely essential in ensuring that we stay ahead of the virus and contain spread of it. And additionally, I would also like to share that there have been times throughout our response that we've had a great challenge in obtaining reagents. So reagents are what you need to actually run the test. Once you have the swab, you need the reagent to get the test result. So we were able, again, to look to our community partner, the Cayuga County Health Department, and the legislator helped us as well in obtaining reagents in order to serve the community in the capacity that was required. So again, I will just thank everyone, all of our community partners. And at this point, I'll turn it over to Dr. Wilson. Thank you so much.
Oh, Dr. Wilson, you're on mute.
Thank you. Thank you, Abby. So it's really been a very remarkable voyage dealing with COVID. During the peak in New York City, many of our nurses traveled down there, and all our para-health professionals, LPNs, PAs, and aides. And remember, at the early days, we didn't really understand the risks. We had an idea, a vague idea, but this was before we had a vaccine. So these healthcare providers were risking their lives, literally, and leaving their families to go and help out wherever needed. And the same thing went for the first days in this hospital. So we've benefited tremendously from the vaccines and therapeutics, which has changed the whole face of the COVID epidemic. let me just touch briefly on where we stand today in terms of the vaccine and therapeutics. So we still have the three main vaccines, the Pfizer, the Moderna, and the J&J. And boosters are obviously available now. And boosters have been shown to increase the effectiveness of the vaccine in terms of preventing severe disease, even with the Omicron. So it's still a very important tool, and everyone should avail themselves if they are medically able to do so. In terms of therapeutics, which we differentiate from vaccines, therapeutics are medications directly to abate spread or severity of infection. We provide therapeutics based on a couple of different criteria. Those that are immunocompromised or felt to be at high risk would be grouped into groups 1 and 2, and those at lower risk, groups 3 and 4. Interestingly, if you're unvaccinated, you sort of go directly to the head of the class and get in severity groups 1 and 2. So you're considered, it's one of the key criteria for being classified as high risk. If someone is considered high risk and they have been exposed to COVID, but are pre-symptomatic, the CDC is recommending a drug called Elusheld, which is an IM injection. Now, it's possibly done as an outpatient. It's an intramuscular injection done twice. Basically, it is a long-acting antibody medication, which is a combination of 2 different antibodies. As late as December of 21, which was really one of the first peer review studies, this was shown to have very robust protection in a high-risk group. So you can see that a lot of this data is just coming across the bow recently. So we're still certainly in the early stages, I think, of definitive therapeutics. If a higher risk individual has recently been diagnosed as having COVID, there are monoclonal antibodies. And again, these are very specific medications, which are quite effective in battling the virus. Sotrovimab is perhaps the most effective monoclonal antibody currently on the market. It's a single IV dose, and it is very effective against Omicron. So that would be a monoclonal antibody, which is given intravenously and right after positivity in a high-risk individual. And then we have 2 main antivirals that are on the market currently. One is a pill called Paxlovid. Paxlovid is what's called a protease inhibitor. It attacks a pathway within the virus replication mechanism. Paxlovid is a wonderful drug, but it does have significant drug interactions. So again, with all of these medications, it's important that they're administered under the guidance of a healthcare professional. Paxlovid is given daily for 5 days as an oral medication. And then remdesivir, which is a quite commonly heard word around the COVID treatment bandwagon. Remdesivir is a 3-day intravenous infusion. It binds to the RNA polymerase. So this prevents virus replication in vivo. The problem with remdesivir is it's very expensive. It's about $2,000 for a course. That's slightly older data, so it probably is much higher than that now. And it's a 3-day course intravenous in the hospital, so it's somewhat limited on availability. Some of the more over-the-counter types of medications, such as ivermectin, hydroxychloroquine, I wanted to mention fluvoxamine as well. These have some anecdotal benefit, but they have not been shown to be significantly effective in any of the carefully structured studies to date. So given the 60 to 80% vaccination rate in the community, a certain amount of herd immunity and or naturally acquired immunity, and these quite effective therapeutics, we can see going forward a decreased hospitalization rate and death rate from COVID, although it's unlikely that it will disappear completely from our population. So that's all I have from the therapeutic side. I can certainly answer any significant or individual questions about that. But again, I want to thank Nancy and Abby for their wonderful presentations. I think we've covered a nice broad spectrum from the personal, emotional, and spiritual side of battling COVID to the nuts and bolts of how a hospital and a Department of Health locally can work collaboratively to rally. And then I've tried to explain a little bit from the medical side. So thank you all very much for your attention.
Thank you very much. Matt, how much time do you think we have? I got a couple of questions, if that's okay. Were you good for just a few questions?
Sure.
Yeah, you guys are okay, Dr. Wilson?
Okay.
Fine.
Are we good with time? Okay.
Yep.
All right. The one question I have, it's more of a statement and a question, is I want to remind the public that you can get 4 free tests from New York State. And they just issued another allowance of 4 more tests of these. I'm not sure if you can see it. These are the home tests. So if you just order them online, you can get them. And my question to the panel is, okay, let's say you're at a particular function and you've been exposed to a lot of people and you don't know what's going on and you want to take a home test. It's not going to be effective from what I understand, like immediately. So if it's not that night you take it. Some people tell me it's a few days. Can you clarify when the test would be accurate? And then what do you do if you are positive? Anybody?
Well, the home test is an antigen test. So it relies on the body's response to the exposure. And so it's not going to be positive in the first 2 days after exposure. So there's a curve over the next, somewhere between 3 and 5 days on when it's most sensitive. And then of course there's PCR test. I'm sorry, I had a senior moment. The PCR test, which is positive for up to 90 days after an infection. So the home test is an antigen test, and it has a variable degree of specificity and sensitivity, but it's not going to be positive immediately after exposure.
Right.
That's good to know. One other question I had was, obviously we're in a transitional period and now you see people with no masks and we have the N95, the clinical mask, and then cloth. Any thoughts on what should we be doing in our community as far as keeping ourselves safe? I mean, I walk into Wegmans and, there's everything under the sun, who's wearing it, who's not. And this is not a political thing. This is like, how do you stay safe? What would you recommend to the average person?
Well, this is, I'd like to make a comment about, in addition to what Dr. Wilson said about exposure. Number one, the most important ammunition that we have is to get vaccinated. So all of us should consider certainly getting vaccinated and boosted. As Dr. Wilson says, the antigen test will not show for several days. So should mask, protect your persons around you, and then wait several days to test. And of course, test if you develop any symptoms. in relation to masking, a tight fitting mask. It's got to be securely on your face. And an N95 is what is proclaimed to be for the public the best source of protection. And Dr. Wilson, do you have anything to add to that?
Oh, well, thanks, Nancy. So, yeah, it's, I think as a population, we need to be aware that COVID is still out there
Yes.
and it's still active. So if you're in a high-risk group, unvaccinated, and if you have some degree of immunocompromise, if you're older, if you have other risk factors such as obesity, then it makes perfect sense, particularly if you're unvaccinated. But I mean, getting vaccinated is job one, really, in terms of being safe. Then a mask makes a lot of sense in public areas, staying away from a close proximity. And masks vary a great deal in terms of efficacy. We've been shown that cloth masks, cotton masks, t-shirt masks, gaiters, and things like that are not effective. A paper surgical mask is reasonably effective. And then the N95 is quite effective if it fits properly. Often it will need to be professionally fit to your face so that it's snug. Those of us in the healthcare profession, unfortunately, find the N95 not particularly comfortable. But I think it's a reasonable option if you're temporarily in a high-risk situation. So we'll wear N95 when we're caring for known COVID patients now.
That's very helpful.
Thomas,
Yep.
I'd like to add to that. So I think for the community, use your judgment. Use your better judgment. If you're going to be around a great deal of people, and there will be people there inevitably coughing or sneezing, or touching multiple surfaces, protect yourself. Use your best judgment. Protect the people at home that you love and care about the most, and get vaccinated.
And as I was saying, it's now come down to a personal level of measuring your own risk and benefit.
Correct.
Yeah, I mean, I don't want anybody else's cold, even if they don't have COVID. So I don't have any problem wearing a mask at Wegmans or wherever. Is there anything else anybody would like to add that they don't feel like they've covered? I was going to say one more thing. I said, do you have any specific recommendations about children? But I don't have too many other comments other than that. So if there's something else you want to add to your presentations, and if anybody has any comments on any special things we should be doing for the kids.
Well, I think the fact that the CDC has backed off a little bit on their early enthusiasm for the under 5 vaccine shows that the system works. In other words, I think we can take comfort as public to know that these government agencies are working diligently for our safety. And so the peer review process, the scrupulous analysis of risks and benefits are being observed. And, I think we're going to get more information about the under 5 population and kids in general as we go forward. But I think we could take comfort the fact that these vaccines, which are obviously created by companies that are making tremendous profit off of them, are being scrupulously observed, and that their product is being analyzed in a very honest way. So that, as far as kids, the word is out still. And I think that there's some personal responsibility to find out what's best for your own family. But I think it proves to us that the process does have benefit, and it seems to be transparent and forthright, which is a good thing.
All parents are in a state of learning as well, and which is very challenging, because there are many other upper respiratory viruses that during the fall and winter. And we also have allergies. What is the number one is your child really keep them home if they have any symptoms of illness. The early symptoms of COVID are very difficult. We've experienced all of the early signs related to other infections. And so it's difficult for us to differentiate. But when we're trying to mitigate and try to limit the exposure for children right now is to keep them home if they experience any symptoms of illness.
Hey, I think we're gonna wrap it up if that's okay, unless anybody has any last minute comments. So let me first thank Jesse Klein, who organizes all of this, who does a phenomenal job, and also Rob Ockman, who bails us out of all our technical problems as we go back and forth to remote and on-site programs. The sponsors of this program is the Wednesday Morning Roundtable Committee, its membership, Tompkins Trust. We also get support from Wegmans, the Allen Foundation, and the Emerson Foundation. So we really greatly appreciate this support, and it will continue on. And this particular program has been opened up to the public, so it's not just the membership that gets this. So they can go, it's YouTube and the Wednesday Morning Roundtable Facebook, Facebook, you can get access to that. And so anybody can see this, and think it's important that this medical information get out to the community. Our next program, which will be in April, will be on workforce development. And after that, in May, it'll be about veterans issues. So I want to thank everybody. Jesse, did I miss anything?
The April and May programs will be in person at Westminster.
Yes, thank you. They will be at the Presbyterian Church. Thank you very much for that. Again, thank you all.